Good morning. This is Dr. Azhar again. So Saturday is always a good day, as I told you before. I hope you're all hearing me. It's funny that sometimes I just think that maybe there's a problem with the mic and you may not hear me, and I just speak and after an hour and go back. So I'm still not used to this online teaching. I'm not really sort of enjoying um, the remote type of teaching. I think I like more of a interactive teaching. We may be able to sort of do a fine tuning, and you may be able to interact through online. There must be a system, but I think because of security reasons, probably we or disciplinary reason, I would say, we're not doing it. Okay. So today topic for discussion is a very boring topic. It's Porphyrias. So Porphyria, I think it's only one page or something like that. You will probably hardly see a patient in your whole life of a Porphyria. I think I have investigated one patient, but in my whole life, when I was doing my clinical biochemistry rotation as a medical officer in the UK. So I was in a unit which is the Porphyria unit, and we used to investigate the patient. And I've only worked there for a month, a couple of months. So, um, okay. Um, so it's definitely not an hour lecture. Okay. Um, so I would say uh, that the other things which we could do is if we can do sort of a learning module, and after that other usually do, and we can do the Porphyria, the boring bit as well. I've got the slides of Porphyria, which are exactly like 32 slides, which probably are not right, you know. Um, so I'm just trying to browse what we can actually do today in terms of a learning module. I'm sure I would be able to decide in a couple of minutes. Probably we will do something. Um, should we do a hospital presentation, chest pain? Last time we did a shortness of breath. Let's see. Okay, so let me just share it. So new share. So you can all see me around here. So this is the hospital position. This is actually BMA, British Medical Journal Learning Modules. which are good for the students and medical trainees, and I found it very useful. I've been doing it for a while now. The time to time they get it changed, and it's very good. So what is the so it's an interactive case-based module for medical trainees covering the differential diagnosis, assessment, investigation, and initial emergency treatment of patients with chest pain. Okay, so at least we can learn something about chest pain. Learning output. After completing this module, what should you expect? Assess the patient with chest pain and generate an initial differential diagnosis. The differential diagnosis, generation of a differential diagnosis is very important. Let me ask one of my colleagues if she can find me a cup of tea. Give me a second. Right. Okay. So I've placed my order. So there are sort of in the tricky bit in chest pain that not all chest pains are sort of cardiac in origin. So there are cardiac and there are non-cardiac chest pains, and you do need to understand the patterns of symptoms and signs. So how do you investigate? Investigation is also very important. So you do series of tests, including ECG, chest X-ray, biomarkers, D-dimers, CT, angiography, and non-invasive stress test. I mean, I know ideally a cardiologist should teach you this, but anyway, since we are here, we will try to learn a bit. Right. Formulate and investigate an initial management plan for patients with chest pain. Okay. So how do you instigate an initial management plan? So start a management plan considering what are the international guidelines about it. You need to know the indications for invasive treatments, or you need to understand your limitations as well. Okay, if you can. Sometimes they don't allow me to do it because I have limited subscription, not full subscription. Really, I'm not wasting hills of money there. Right. Okay. Sounds a bit fishy there because sometimes when it's due like this, it means it's not going to allow you. Well, it has. Okay, let's start. So pre-test questions. So you're just finishing assessing a 79 years old man. So old, chest pain while digging in the garden. So he was having a chest pain while he was doing some work. So chest pain exertion. So it was associated with the sympathetic symptoms such as sweating and nausea and lasted for an hour. He's an arteriopath. He is hypertensive. He has got CKD stage 3. So he's got risk factors. So they gave him aspirin and GTN spray, which did not relieve his symptoms. But on arrival to emergency, his chest pain was settled. High sensitivity troponin, you have reviewed 12-lead ECG, which appears normal. Few minutes later, looking after him asked you to review him again as his pain has just reoccurred. He describes central pain and looks very calm. He was hypertensive. His ECG now showed ST segment depression in lead 1, 2, 3, AVL, V5, and leads, so inferior leads and lateral leads. And repeat ECG showed there is no posterior leads problem. We prescribe a pain relief and for immediate administration. What is the most appropriate step in his management? Start an ADP receptor antagonist. Start an ADP receptor antagonist and subcutaneous fundoparexin, fundoparinax. Start an ADP receptor antagonist and intravenous unfractionated heparin. ADP receptor antagonist, and bivalirudin tyrofibin. We will read about all this stuff. Just hold on a second. Okay, so he may well need a subcutaneous, so he probably has got a and STEMI, I would say, known as stimulated MI or an ACS, and he should be given a receptor antagonist and subcutaneous Vendaparonex. Just above to assess a 47-year-old man who's born to administer with acute chest pain. The primary suspect patient has acute thoracic aortic dissection. Which one of the following would be reinforced? Weakness, dysphagia, crackles, peripheral cyanosis, an irregular pulse, tenderness over the central chest wall. So weakness left arm and leg and dysphagia is a CVA. Crackle at the left base is probably a pneumonia. Peripheral cyanosis, maybe in pulmonary embolism, it can happen. An irregular pulse, atrial fibrillation, tenderness over the central chest wall. Right. It's tricky. So maybe the peripheral cyanosis. So you're reviewing a 54 years old woman in the outpatient clinic. Okay. She complains of exertional chest pain. For the last 4 months, she's having exertional chest pain, which feels tight band across the center of her chest, and on occasions radiates to her back. A general practitioner has prescribed a sublingual nitrate spray, which she takes and pains within 2 to 2 minutes. But she has needed to use the spray a bit more, so she's getting more angina, more frequency angina. 10 cigarettes, hypertensive, on low sartan, ECG is normal, which is the most appropriate investigation to confirm the diagnosis. You do exercise treadmill test, Dopamine stress echocardiograph, first pass cardiac MRI perfume and computed CT angiogram. So she's going to be worsening of angina. So to confirm the diagnosis, her ECG is normal. Getting angina. She never had an X-ray. So let's do a non-invasive test, either X-ray or Dopamine. 48 years old man in the outbreak clinic for a follow-up visit. He described central chest tightness and breathlessness when walking to catch the train to work each morning. The central chest tightness and breathlessness. His symptom worse in the cold weather. He does not use glycerol GTN spray. He recently had coronary angiogram, which is reported to show tight stenosis in the mid-anterior left, mid-LAD and right coronary. His serum cholesterol 5.6. And you're starting to give him treatment with statins. So what else? Offer invasive coronary angiogram and myocardial revascularization to improve the prognosis. Organize a functional imaging to say that his symptoms are due to myocardial ischemia. Offer treatment with calcium channel blocker with follow-up to assess symptoms response. Offer treatment with ranitidine with follow-up to assess symptom response. Offer treatment with nacorendil. So what additional advice you are going to give? Either you organize a functional imaging to confirm the symptoms are due to myocardial ischemia, or you do a coronary angiogram and revascularization. So I think if we already know that, so you probably will do this. Okay, a 23-year-old woman presents with left-sided sharp pleuritic chest pain. You want to exclude pulmonary embolism as the cause of her symptoms, and well score is 1.5. What test would you do next? So I would say 12 lead ECG, chest X-ray, and D-dimer. Okay. So we have been asked by the medical registrar to assess a 74-year-old man in the emergency department. He was brought in by ambulance. Acute episode of chest pain while watching TV. Pain lasted 30 minutes, completely resolved. No abnormalities in the ECG. Hypertensive, obese, smoker. So he having symptoms in front of you. There was calming, pallor, tight band across his chest. Sounds like a typical ischemic chest pain. Feels a bit breathless and nauseated. Okay, what is the most likely diagnosis? Acute coronary syndrome. So that's correct. Right. When taking a chest pain history, so what will you do? That's very important. Location. So you remember those 6 points. Thank you. So my tea is here now. So you remember those points, okay? So then location, radiation, frequency, severity, duration, factors aggravating, associated symptoms, description of the pain, any risk factors, smoking, hypertension, age, diabetes, hypercholesteremia, premature coronary artery disease, cocaine. So what are the known causes of non-coronary causes of angina? Severe aortic stenosis and hypertrophic cardiomyopathy. The coronary vessels are normal, but patients get angina. Feature of ischemic chest pain is suggestive of acute coronary syndrome. Tightness, pressure, band, jaw pain, more than 15 minutes with nausea and breathlessness. So these are all sort of typical features. Less helpful in differentiating ischemic pains from other pains. GT and spray response is no, nothing. There is no difference in ethnic group. Lack of response to antiacids. These are all less helpful. Esophageal spasm can present with symptoms like myocardial ischemia. Pulmonary embolism can present with chest pain, but that causes a pleuritic chest pain. Aortic dissection can cause chest pain, but that chest pain describes to be radiating through the back. life-threatening tension pneumothorax, myocarditis, esophageal rupture. These are life-threatening causes. History don't confirm the diagnosis, but it will help you to guide your investigation and management plan. So whenever you actually come across with the chest pain, an acute ischemic chest pain, you give patient a GTN spray to relieve the chest pain and give a 300 milligram of aspirin. So always open-minded about the diagnosis. Some people will don't develop it, develop atypical chest pains and atypical symptoms. Exertional breathlessness, pain with different vectors, all are ischemic pains. So let's know more about the more causes of chest pains. So with no confirmed, 30% of chest pains are with no diagnosis. Around 25% angina. So whole of ischemic heart disease, sort of ischemic chest pains comprise around 32%. And around minority is between 11 and 13% is non-pulmonary causes or other causes. Aortic dissection minor, and pulmonary embolism is only 0.4, so it's not very common. So 30%, 3 out of 10 patients will have ischemic heart disease. Okay. So let's go back to our patient. So you examine Mr. H using the ABCD approach. So, okay, airway, breathing, circulation approach. He's pale, clammy, and pain. His pulse is regular. Blood pressure is on the lower side. Saturation is fine. His GFP is not raised. He is not in failure. Which investigation, 2 investigations would you recommend? So I would recommend the patient a 12-lead ECG and saturation is 95%, chest is clear. And serum so that's correct. I can hear a few noises at the back. You want to talk to me? Okay. So the correct answer here is 12-lead ECG and serum troponin. So the key to establish the diagnosis of acute coronary syndromes are what? So cardiac biomarker, which is the troponin, and 12-lead ECG. 12-lead ECG will show you ECG abnormality, and the biomarker will be high. Chest reaction is important if there is evidence of heart failure, JB is raised, or there is an evidence of a pneumonia or a pneumothorax. Chest sounds are a bit dodgy. But that will not help to diagnosis of ACS. Okay, so what's the practical tip? The routine use of chest X-ray to assess the wider mediastinum and as aortic dissection is not recommended. I mean, there's a bit of background noises, so we probably are going to mute you guys. We're rather talking to each other. So, plasma D dimer. So D-dimer in patients with activation of coagulation and fibrinolytic symptoms. A normal D-dimer is a high negative predictive value for venous thromboembolism. D-dimer doesn't confirm to confirm the diagnosis of ACS. CTPA is a diagnostic technique for PE. It's not for the acute coronary syndrome. So diagnosis of acute coronary syndrome is based as an umbrella term, okay? ST segment elevation, non-ST segment elevation, and unstable angina, all three are in acute coronary syndrome. Classification of ACS according to the results of ECG, serum troponin, and coronary angiogram. So investigation, ECG, was STEMI, elevated, STEMI complete or near complete obstruction of the coronary artery, incomplete or transient obstruction in STEMI, and incomplete or transient obstruction in unstable angina. NSTEMI is testive depression, unstable angina, and NSTEMI, you cannot be sure on sort of the diagnosis on the ECG is about the cardiac enzymes. So there are three types of acute MIs. It's classified as an evidence of acute myocarditis in the context of rise and fall in the serum cardiac troponin. Clinical evidence of acute myocardial ischemia include at least one of the following symptoms of ischemia: new or presumed new ACG changes, development of new pathological Q waves, imaging evidence of new loss of myocardium, identification of intracoronary thrombus on angiography. Okay. So the ECG should interpret in the context of the history and examination finding. ECG leads with ST segment elevations. So if there are these elevations in V1 to V4, it's an anteroseptal and it's LID. If it's V5, V6, 1 AVL, it's likely circumflex, lateral side. 1, 2, or 2, 3 AVF, inferior, right coronary or circumflex. V7 to V9, posterior leads, right coronary or circumflex. 2, 3 AVF, AVL, V5 to V9, infraposterolateral, dominant circumflex. So these are the ECG findings, so you can guess on ECG what coronary artery is involved. So this is an evolving ST segment elevation MI, okay? With the G-wave inversions. So in posterior MI, suspicion ECG evidence of inferior or lateral STEMI. So here you put the posterior leads, V7, V8, V9, around in the scapula. Placement of the right sided chest leads. So you do it at left side, you do it here, and right sided, you do it here. Always look for an old ECG. Okay. So cardiac troponin complex is the component of cardiac sacrum where and plays role in the heart muscle contraction. The cardiac troponin complex is comprised of three subunits: troponin T, I, and C. Myocardial necrosis causes cardiac troponin to leak into the bloodstream. The serum levels of cardiac isoforms troponin T and I are sensitive and specific markers for myocardial injury. In patients with ischemia, a rise or fall of cardiac troponin above the 99th percentile above reference limits indicates following a large myocardial serum troponin level remains raised for 2 to 3 weeks. So with the introduction of high sensitive cardiac troponin assays that can reliably detect low levels of serum troponin. High sensitivity troponin is used to rule out MI. Rather troponin T or I when the patient is first assessed in the emergency department and a second test 3 hours later. A diagnosis of NSTEM is highly unlikely if serum troponin is normal. If patient presents more than 6 hours after the onset of acute chest pain, the initial troponin is not elevated, repeat troponin after 3 hours is not needed. The diagnosis of myocardial infarction can effectively be excluded. Acute chest pain, high sensitivity troponin, pain is more than 6 hours, is not raised, discharge, or you do a stress testing. Pain is less than, you do a repeat troponin in 3 hours, no change, stress testing. One value is above level of normal. You do invasive management if the troponin is above normal. If there is a no change after 3 hours, you do a workup differential diagnosis. There are a number of other conditions that can cause elevated high sensitivity troponin levels, including tachyarrhythmia, sepsis, renal dysfunctions, cardiomyopathy, severe bleeding, aortic dissection, pulmonary embolism, pulmonary hypertension, intracranial events. For example, subarachnoid hemorrhage and subdural hemorrhages, they all can cause higher levels. Seizures can cause, strenuous exercise can cause. So whenever the ACS is not suspected, you do not use a high sensitivity troponins. That was a bit about troponin myth. So this was the 12 lead ECG. You see the ST depressions. So this is ST segment. So you see, I'll tell you a bit, but this is QRS complex. So Q, R, S. So this is QRS complex. So this is ST segment. So this is ST segment. So you see ST segment should be here. So it is depressed and C wave inversions in 1 AVL, 2. So this patient, so for insufficient, which of the following diagnosis is most likely? Non-ST elevated MI, unstable angina, left ventricular strain pattern, that's a bit, to be honest. It could be unstable angina if there is no rise in the troponin. Okay. So what does the ECG shows? So the ECG demonstrates ST segment depression. In the anterior V1 to V4, we see the depression and the lateral leads. Suggestive of acute coronary symptoms. The pain persisted for 30 minutes. with the ECG changes suggested as he had a severe episode of myocardial ischemia. Therefore, it is likely that troponin is elevated, which excludes the diagnosis of unstable angina. It occurs at rest, so this is not a stable angina, but this is unstable angina. If there is if on the ECG there is, I would say, ST segment elevation, you suspect an acute STEMI. So how do you do it? So the J point elevation, the two contiguous leads, 2 millimeter or more in men 40 years of age or older, 2.5 millimeter in men age less than 40. So 2 millimeter in men who are older than 40 and men who are younger than 40 would have 2.5, and 1.5 is regardless of age. Patients who suspect acute STEMI should be referred to the emergency reperfusion therapy if timely primary angioplasty is not available. So let's do this bit. So what you do in emergency treatment for reperfusion therapy for STEMI. Immediate primary percutaneous coronary intervention is the preferred reperfusion therapy for patients with STEMI and is associated with lower mortality and stroke rates. So immediate primary percutaneous coronary intervention. Fibrinolysis is associated with 1% risk of intracranial hemorrhage. Common agents are alteplase, tenecteplase, ritaplase, so TPA. So if it's delayed for more than 2 hours, you give fibrinolysis. So either you do a primary angioplasty or do a rescue angioplasty. So rescue angioplasty is when you do a fibrinolytic therapy and then you do an immediate cardiac catheterization. So if there's an evidence of failed reperfusion record, like ECG 60 to 90 minutes after initiation of fibrinolytic therapy, is defined as less than 50% resolutions. Patient should be considered for emergency coronary artery rescue of ECI. ST segment elevation in lead AVR, especially in the presence of other ischemic ECGs associated with the proximal triple vessel coronary vessel disease, severe left main stem, or proximal LAD. Patients with the persistent ST segment elevation in AVR and symptoms, ischemic symptoms, should refer for a coronary angiography. Mr. H. pain gradually settles and his ECG change resolves. His baseline sensitivity troponin T is in a laboratory reference was 40, so it was high. Which three of the following should you do now that a working diagnosis of NSTEMI has been confirmed? You do admit to acute cardiac unit. You give high flow oxygen. You don't fibrinolyze these patients. You risk stratify the patient. I think so. Partially correct. So maybe you give to antidual treatment. Okay, admit to acute cardiac unit, offer treat. So don't give high flow. So that was the not. So grace the 2.0 score. So this is. So I'll probably go through this slide in a bit detail. So this is the crux of our presentations of chest pain. Okay. So you admit to acute cardiac care unit. You offer treatment with dual antiplatelet therapy, aspirin and clopidogrel, and you give fundopyronex. So all three can be given. So fundopyronex, unfractional heparin, or low molecular heparin, all three can be given. All three means any of these three can be given. Risk stratified. All these patients will be managed with acute cardiac events. Okay, so the high flow oxygen may be detrimental in patients with ACS. So you give more oxygen to hypoxemic area of the myocardium, which causes more vasoconstriction and increases the size. So British Thoracic Guidelines recommends titrating the oxygen saturation to 94 to 98%. So liberal oxygen therapy is increased mortality. Fibrinolysis has no role. It should be given with aspirin and ADP receptor antagonist, clopidogrel, prasugrel, or ticagrelor, an anticoagulant. Fundopyronex should not be used if PCI is planned within 24 hours. The use of glycoprotein 2B, 3B inhibitors in patients with ACS waiting to go to catheter lab has decreased, especially in the area of more potent antiplatelet agents. Okay, so the use of glycoprotein 2B and 3B inhibitors, so tirofiban in patients with ACS. Not how these agents may be used selectively in unstable patients with ongoing chest pain if delayed to coronary angiogram. So if the patient has ongoing chest pain apart from the dual therapy, you may give this. A thrombin inhibitor, a bavellorigine, a thrombin inhibitor. So this hasn't got any role. Nice guidance recommends the use of relative risk scores such as Global Registry of Acute Cardiac Event score. So GRACE 2.0 score to risk stratify ACS. The following flow diagram is not suggests that STEMI reversal of patients presenting with ACS. So STEMI activate PCI pathway, load with aspirin, full protocol, emergency coronary angina, admit to the cardiac event, secondary prevention, cardiac rehabilitations. And STEMI angina, so you do with aspirin and ADP inhibitors, admit to the patient to do a GRACE 2 score. High risk, that is impending shock, pulmonary edema, or dynamic changes, coronary angiogram and angioplasty, stabilize with no or minimal chest pain, decide management strategy on early invasive coronary angiogram, 72 hours of chest pain, or medical management of ACS. So it depends on the GRACE score. Okay. The 3-hour sensory drop levels response to the lab, it is elevated at 367 after 3 hours, so it has gone very high. which confirms the diagnosis of anemia. His creatinine is normal. His 6-month mortality is calculated as 15%. On the following day, he had a tight stenosis of LAD. LAD lesion is treated with stenting and is ready for the treatment. Which two of the following statements are correct? Echocardiogram must be performed before discharge and again 6 to 8 weeks to assess ventricular function. He should be advised. He should be advised not to drive a car for 3 months. He should continue anti-dual therapy for 1 year. He should have routine coronary arteriography in 6 months' time. Lifestyle modification reduces mortality and morbidity. So this is, think, lifestyle modification. It's a partially. So which two? Okay, so I would say this one as well. Let's continue this. You should have a dual antiplatelet therapy 1 year. So 1 year dual antiplatelet therapy. Nowadays, people have all sort of antiplatelet therapy all life. Lifestyle modification and cardiac rehabilitation reduces mortality and morbidity. Concerning the driving, you can drive after 1 week after an ACS. No other revascularization planned. Ejection fraction is at least 40% before hospital discharge. There are no other disqualifying condition. Suggests that all patients should have their LV function, so the echo should be done prior to discharge, but the re-echo in 8 weeks in some patients, but not in all patients. The patient should continue aspirin ADPM for 1 year. The risk of bleeding is high. European duration can be shortened for 6 months. No follow-up coronary artery. There is no symptoms. High-dose statins, beta blockers, and ACE inhibitors in all patients with ACS. A mineral corticoid antagonist, spironolactone, aplerenone, is there evidence of reduced ejection fraction. Cardiac rehabilitation programs are very, very important. Okay. So let's summarize what we have discussed. The features of pain suggestive of ACS will include a sensation of tightness, pressing on the chest, center of the chest, and pain in the arms, back, neck, or lower jaw. Sometimes people use a clenched fist on the chest when describing the pain. Term ACS is actually an umbrella term. NICE guidelines advocate the high use of troponin in the arm level, the hospital, and 3 hours after the hospital is suspected. So what you do is you check the troponin on admission and you check the troponin after 3 hours. Okay, so we close the module here. So let's do the new screen. Right. So Porphyrias. So what comes into your head, when we talk about a porphyria? So I think it's a one page or something like that. And David said there are different types. So there are cutaneous porphyrias, where there's a skin involvement, and there's a non-cutaneous form, porphyrias, where there's no skin involvement. And then there's an acute porphyrias, and there's a non-acute porphyria. Okay. So just to tell you a bit of basics, what actually is happened in porphyrias. So there's a group of disorders that results from a buildup of natural chemicals that produce porphyrin in your body. So these porphyrias, why these porphyrias are important? Because the porphyrin is essential for the function of the hemoglobin. So these is linked with iron, is linked to porphyrin and binds iron and carries oxygen. So hemoglobin is linked with the porphyrin and it binds with the iron. High levels of porphyrin can cause significant problems. So there are generally two types of categories of porphyrias. Acute, which mainly affects the nervous system, and cutaneous, which mainly affect the skin. Some porphyrias have both nervous system and the skin. Specific type of the porphyria will dictate what signs and symptoms will come. So, okay, so let me tell you something about that. So this is anemia, okay? So that's MCV, which is a normal MCV, raised MCV, and less MCV. So porphyrias, you get microcytic anemia. So there is a defect in the hemoglobin synthesis when there's a microcytic anemia. Okay. Let's do this. Okay, so defect in the hemoglobin synthesis where? We find to find out. So the iron is, so iron and iron binding capacity. If the iron is low or normal and iron binding capacity is high, this is the iron deficiency. If the iron is normal or iron is high and iron binding capacity is low or normal, but still there is a defect in hemoglobin synthesis. So where the defect is in the porphyrin synthesis, heme synthesis or globin synthesis. जी अस्सलाम वालेकुम, मैं लेक्चर ले रहा हूँ इस वक्त, अब बाद में मुझे फोन कीजिए. So let's see defects in the porphyrin synthesis, heme synthesis, and global synthesis. To do hemoglobin electrophoresis. If it's abnormal hemoglobin electrophoresis, there's a defect in the globin synthesis. So you can have sickle cell anemia, thalassemia. If the hemoglobin electrophoresis is normal, then there's a defect in porphyrin synthesis or heme synthesis. So what is heme composed of? Heme composed of erythroid and non-erythroid. Okay. Erythroid is a hemoglobin, and non-erythroid is a hemoproteins, which electron transfer and energy trapping. So porphyrin synthesis. Porphyrin synthesis happens in two phases, in the mitochondria and in the cytosol. Okay. Let's skip this. So what are the main types of porphyrias? So main types are acute porphyria and non-acute porphyria. So this is the biochemical pathway. So you do a glycine, this is the mitochondria, this is cytosol. So glycine plus succinyl-CoA, they combine with ALA synthetase and form an ALA. Porphybilinogen is formed, and then the porphybilinogen deaminase, which makes it hydroxymethyl bilane. Methylbilane will change into Uro3 to copro3 to proto3, and protoporphyrin 9, and then into heme, which is linked with this. So there will be problems at different levels. So acute porphyria, Either you have a deficiency, but the enzyme deficiency, if you're intermittent porphyria, hereditary porphyria. Secondary porphyrias, you get in lead poisoning, in iron deficiency, and in coproporphyria. So more important is an acute intermittent porphyria, which have neurological symptoms as well. So acute porphyrias, the symptoms may last for days to weeks. Cyanum symptoms of acute porphyria include severe abdominal pain, chest pain, constipation, nausea, vomiting, red or brown urine. So red or brown urine is very important. Patient can have confusion, hallucinations, breathing problems. Cutaneous porphyrias have skin problems. So there may be a problems with the genetics, autosomal dominant inheritance or autosomal recessive inheritance to cause these porphyrias as well. Okay, so as I've told you before, acute porphyrias, the tissue expression is in the liver. The non-acute porphyrias tissue expression is in the liver and the erythroid cells. Almost all are autosomal dominant except allele deficiency and congenital erythropoiesis recessive. I think it's a bit about our porphyria. I'm going to leave you in peace for now, and thanks for listening.